Great. Well, hello everybody, and this is our first Nightingale Challenge Global Solution Initiative for 2021, and delighted to be here with some fantastic colleagues that's on this occasion is going to put the spotlight on the importance of nourishment and nutrition. So it's my great privilege to spend the next hour with you, and we're going to start with the fantastic Jane Clark that's going to talk about the role that she plays as the founder of Nourish. So Jane, over to you.
Oh, thank you, Lisa. As you say, we've got a really lovely group this afternoon, so it's great to be kicking our time off together. So I'm truly honoured to be here because I think what's really exciting about the time now is that we have an opportunity to do things really differently as a world. And for me, my whole upbringing as a child was that food was at the centre of my world. It was my great aunt who was my absolutely adored aunt, but the way that she showed her love and affection to me was through the Chelsea buns, the wafts of homemade food when my sister and I used to stay over. And it was that really evocative way of seeing that food for me was emotional, it was connection, it was love, it was joy, it was celebration. So I went into my dietetic career with that as a real backdrop, because I really wanted to make a difference to people's lives through food. So I went to university and did my 4-year degree. And you might think, oh gosh, I'm really lucky to have done that degree. And to some extent, yes, I was. But I had the naive thought that I would come out of a 4-year degree with both an amazing knowledge of medicine and an incredible knowledge of food and how we can create the most delicious food to support people, whatever their health challenge is. I came out with one and I came out without the other. I came out with enormous knowledge of medicine and food and health, but I was appalled at the way that food was taught to us as dietitians. We were taught as an example, and you'll all have them, is I was shocked that when we were told that if someone had dysphagia, which is a difficulty in swallowing, that what you did is you took their normal food. So you took their roast beef, you took their piece of chicken, you took Brussels sprouts, you took anything, you took chapatis, you took dal, you took anything, and you just liquidized it and bunged it in a bowl and served it as a mush. And I said, that's not dignified, that's horrid. That's not what I want to be doing for my patients. So I realized that I needed to really craft a different career. But I thought, stick my degree out, get my degree. I did my cordon bleu after I did my degree. And I went back to my Auntie May food roots. And that was really the start of my career. So we're going back, way back when, 30 years. And I was the first dietitian in Britain to set her own private practice up. And when I rang my professional body and said, I want to set up my own practice that really shows people about how you can truly nurture someone and nourish someone through food. And they said, well, that's not been done before. You can't do that. That's not how we do things in Britain. And I said, look, if I ever did things just as we were told that we should do things in Britain, I never would have got off my backside and done anything. So I said, look, I really want to create an amazing practice where food is at the center. And this is what I'm really putting out the big plea to all you new nurses and midwives to say, I know, because actually a part of my story is that I was also very ill, seriously unwell from the age of 15 to 25. So I lost about a quarter of my life in hospital. So every month I would go into hospital, spend a week, 10 days. And I knew that the couple of defining things happened for me in hospital. To know that the food certainly wasn't something I loved. It was just not how I wanted to be looked after as a patient. But also there were those nurses that would just come and sit at the bottom of my bed and just make me a cup of tea. And it could be a simple digestive biscuit. And they'd just stop and they'd listen and they'd share. And I just knew that it doesn't have to be complicated. It's actually that stopping moment and saying, let's use food as a little communicator. And this is what we've got the unique stance to do, this unique moment in history, to say in our communities, whether you're in a very medicalized community, whether you're out in the community, you're doing your amazing outreach work around the world, how can we do nutrition and nourishment differently? So that's the challenge I'm really setting to you I'm not talking about millimoles, micromoles. How can we get, a certain clinical outcome from a patient? Because if I go back to all of my work over the 30 years, and I've been involved in amazing campaigns, like I worked with Jamie Oliver on his Big School Meals campaign. And that was the first essence of seeing that we can change society by people power. We're not just going to create policies and just push it down into society. We were the school dinner ladies, we were the mums, we were the grands, we were the healthcare professionals to say, wow, we can really do things differently. And this is a wow moment to say, as nurses, as midwives, you know what goes on with your patients. How can we be creative? And as we put in the title, think outside the box, go wild, because unless you go wild, you'll never really see that we can do it really differently. So through everything I do, whether I'm looking after my patients, I look after a lot of patients that are very vulnerable. And I also run a big community called Nourish by Jane Clark, where we connect through food, we connect through recipes. When we get past COVID, we connect through our afternoon teas, we connect through drinks. And it's all about that simple gesture that delivers nutritional outcomes, but it does it with dignity, respect, deliciousness, and real care. So I'd love to hear all of your ideas. Flood me with them. And then we've got some amazing prizes, which we'll talk about later. But I just say, let's just seize this moment and educate and inspire each other with as many creative ideas as we can.
That's absolutely superb introduction, Jane. Thank you so much. And I'm delighted that we've got people here from the UK, from Ghana, from India and Maldives. So it'll be really good to hear what fantastic out of the box ideas that come from those super countries. But just that emphasis on connecting through food. Jane, you ignite me with new ideas every time I listen to you, and I think we really want this community to think new and differently, don't we, about how
Yeah.
you can do this, which is just so exciting, and it's a gift in all of us, I think, to be able to
Yes.
come up with these ideas. It's possible, isn't it? It's not an impossible thing that's beyond our realms. So that's another really exciting thing for people to think about as they're mulling over this next solution initiative. So we're now
Yes.
go on,
Yeah.
Jane. What was you going to say?
I was going to say that because if you ask any patient about their experience of
Mhm.
being cared for, so often they talk about food. That's
Mm.
the first thing. Oh, I had a lovely cup of tea, or I had a lovely bowl of soup. They don't start saying, oh, well, I achieved my clinical outcome today, or I achieved this. This is where up until now we've got things really wrong. It's about how do we think about that simple food gesture
Yeah.
about delivering nourishment to someone. So yes, let's just open up the debate.
Brilliant. Thank you, Jane. And we'll come back to you later because we've got opportunities for questions and answers towards the end of this webinar. So please do put your questions into the box for those of you that are listening. And we're now going to hand over to Marjorie. So Marjorie, over to you.
Okay, thank you, Lisa. I'm just going to try and share my screen now. Okay, can you see that? Yeah, people can see.
Yeah.
everybody's on mute, so I can see the heads nodding. Okay, so I just put a few slides together just to introduce myself and where I'm coming from on this. It's lovely to hear Jane talk passionately about nutrition, because I think that's what we all need to be thinking about doing right now. I've been a nurse educator for 20 years. I've been in nursing for over 20 years, but mainly in mental health nursing. And I got to PhD level by looking at how we could, like Jane said, empower people to take more control over their own health, particularly in mental health for me, but it was also helping people to see that they could get their lives back on track, no matter what illnesses they were suffering from, with a little bit of help from us, hopefully. So I asked people what they wanted, how that help might look like to somebody who's got in the other shoes, if you like. We talk about talking in the other people's shoes, but we need to know what they think about things like that. It's not good us as professionals just saying we know what you need. We need to find out what the people need so we can help them. So my PhD came out after many, many words with one word, which was compassion. That's what people told me they needed to help them take control back over their lives. They just wanted us to listen to them, basically. And since completing my PhD, I've been writing a blog around compassion and how we can incorporate it more into nursing. I know many people who are nurses already know that it's a controversial subject, but I think we can do it. So more recently, I've got interested in nutrition, especially over the last few years, of how we can help people manage their own nutrition instead of, being totally dependent on medication and treatments. And just on this front slide, you can see, I know this is being recorded, so there's a link to my blog site there with all the evidence that I'm going to be talking about right now. Now I need to work out how to move it. Okay, so just thinking about in your own area of practice why nutrition is important. And there's lots of reasons there, but I'm learning particularly about things like micronutrients and macronutrients, how all those things come into play when we ingest them on our every individual cell in the body, and how it can lead to sometimes something called more recently leaky gut, which is, that basically our digestive system not working very well and leaking toxins back into the body, which is causing inflammation around the rest of the body and in all the major organs. So it's not just about mental health. It can even be about unborn children. If the parent has not had very good nutrition while they've been pregnant, then it can lead to heart disorders in adulthood for those children who haven't even been born yet. So there's lots of things we can look at in nutrition. It's not, it is about helping people to eat better, but also how we can help improve their health. And there's been a lot of research on it in the last few years, and things about insulin sensitivity and why people are becoming so obese, basically. So in mental health, we've had a long history in mental health of neglecting people physically and, just focusing on their mental health, and perhaps we haven't been looking at their physical health. But I think with the introduction of more medications in the last 20 years, it's shown us that the medications are working, yes, but it's increasing people's weight and we don't know why. Is it because they're lacking motivation to cook properly, or is it because there's something going on with that medication in their body that's causing them to, and we do know this from some drug companies, that it's switching off their appetite suppressant button in the brain, if you like, so they're constantly hungry. So if somebody's constantly hungry, we're going to have to learn how to help them manage that in a more nutritious way, rather than just filling up on food that they think is going to make them feel better. So, like I said before, it can be deficiencies in essential micronutrients like vitamins and minerals, and Tracy will be going into that in a lot more detail later. It might be that they are increasing that should be macronutrients, their carbs and their fats, which is leading to obesity, and type 2 diabetes, we all know, is on the increase. There's also a thing called metabolic syndrome, which is it's not a disorder or a disease, it's just a cluster of symptoms that indicate that somebody's high risk of death through either cardiac disease or diabetes. And that's often measured by girth, so if somebody is higher than 37 inches for a man and 31 inches for a woman, around the middle, then that puts them in the high risk zone, as well as high blood sugars and high blood lipids. So going back to the leaky gut idea that's out there at the moment with insulin sensitivity or insensitivity, it's poor function at the cellular level, basically. So the insulin is not doing its job properly in type 2 diabetes and in obese people. And then, as well as at the cellular level, if the insulin is not doing its job properly, we're getting a trigger of the immune system, which is causing inflammation at that level, which leads to what we call oxidative stress. And that's actually damaging to our cells. So if our cells are getting damaged, that's when disease can start to set in. So like I said at the very beginning, compassionate nutrition is about listening to the person and what they need. It's no good as going out there and telling people what they should be eating if you've got no idea of their individual needs. So it's really important just to get to know them. And in mental health, we're well known for sitting down and drinking tea with people, but it's a really important intervention through getting to know them and what their needs are. I wish somebody do some research on having a cup of tea with somebody. And it's also helping them to build up their own empowerment, but also their own resilience. And it can work both ways. It can work for us too in the profession, that we start to be more reflective about what it is our aims are and our goals are, even for ourselves, and to work out how we can do them that's going to benefit both us and the person that we're working with. Because if we're working in conflict, then we're probably not going to get very far. And just to show that compassionate nutrition is not really a new idea, although not many people talk about it in this way, Florence Nightingale is recognised as one of the important people who drew on the idea about nutrition and hygiene with the soldiers in the Crimean War in the 1800s. I don't know whether many nurses know this, but she was the first person to invent the pie chart. And she did this apparently so that people would take notice of her, because she didn't think they'd listen to her words if she just wrote them in letters. And she did write many, many, many letters. So if you can see this screen, I probably see it larger than you do. The pink area is deaths from all of the causes. The dark grey area is deaths from wounds, and the light grey area is deaths from preventable diseases. So she recognised that through nutrition and good hygiene, she could prevent a lot of those deaths in that war. And that, as we often think with war, that people die from the injuries, she realised that they weren't dying from their injuries, they were dying from things like poor nutrition and poor general health. So it's a basic part of our care really as nurses, to look at people's nutrition and to see how we can help their nutrition to improve. So in turn, that will improve their overall physical and mental health. So we can talk to people and get to know about the macronutrients, what they're eating. Food diaries are a good way to start. And I'm sure Jane will talk about this as well, but it's not just about calorie counting, it's about nutritional density, which is quite an important thing to be looking for. So we're not just about thinking about feeding people up, as we used to say, but making sure they get that nutrition in. And that's the important thing for healing what's going on inside the body. Testing for deficiencies and absorption problems, which Tracy will mention. And just educating people about consuming foods high in micronutrients and low fat and lowish carbs. So that I've just put there some of the things that you could think about. And even when we're, at work, thinking about what sort of diets and food we're offering people when they are in hospital. So just to finish with, just a few diagrams there about sort of things that you might want to be looking out for. Fibre is a big one, because that's so important in helping the digestive system to work effectively. And also looking at what the sort of macros and what are the micronutrients. Like I said before, they're mainly the vitamins and minerals and micronutrients. So the macros are all the other things like the carbohydrates, the fats and the proteins, which we know are good for building people up. It's getting the calories inside them, but thinking about, where's that protein come from? Where's the carbohydrate come from? And where's the fat come from? And is it healthy fat, or is it not so healthy fat? Is it organic? Is it not organic? And has it been processed? So I think processed food is probably one of the biggies that can have a lot of calories, if you ever read your labels, but very little nutrients in them. So I think I just want to finish there with that. I don't want to overload people with information. But it's just to give you a general overview of what you might need to be looking out for.
Well, thank you so much, Marjorie, and I really like that visual, because I think something that is often a challenge for many people, for health professionals and people that are not health professionals, is understanding the complexity around diet. And I can see Jane nodding because of certainly in the UK, I think over the last 20 years, we're bombarded with different diets and
Yeah.
things we should eat, things we shouldn't eat. And I think that's not helpful to us. And one of our lovely people listening from Ghana has talked about community health nurses in the chat box, and how they go as far as bringing ingredients and meals to their units to demonstrate how to do food well for their children and to nourish them. So a brilliant example there that's incredibly holistic from Ghana that Stephen, I'm sure we can learn lots from. So yeah, that's really helpful, Marjorie. And again, if people have got questions for Marjorie, please do put them into the box, because we'll have a chance to speak to Marjorie at the end. And let's not underestimate the power of a PhD and all the work that you had to do to get that PhD, Marjorie. So a font of intelligence there that's definitely worth tapping into. So it's my delight now to hand over to Tracy, who is currently in the depths of doing a PhD. So many congratulations, Tracy, to you for embarking upon that at the University of Bangor. And you're going to talk about B12 deficiency and what you're learning and studying in that space. So thanks for joining us, and over to you. You're just on mute at the moment, Tracy. It's normally me that does that.
What I would do.
There we are, sorry.
Are you there?
Great, we can hear you.
Right. Thank you for that, Lisa. And yes, I'm delighted to be doing a PhD further studying B12 deficiency, and I'm very lucky to have Marjorie as my supervisor. So I'm going to share my screen with you. If can you see that? Let's see.
Let's do this.
Sorry, guys. I did practice this before.
Yeah, try that.
There we go. Share screen. This one. So you can see my screen now then, can you? Okay, so I started my website b12deficiency.info in 2013. I have no medical training, and the reason I started my website was because somebody close to me was sectioned with B12 deficiency. And for anybody outside of the UK, that means held in a mental institution for 30 days. So with the website, I felt it was important. I have no medical training whatsoever, but I wanted to try and get key bits of information to health professionals and to patients who might find themselves with B12 deficiency. Anything I talk about today you can find on the website. So B12 deficiency is a demyelinating condition. It affects your central and peripheral nervous system and the blood and bone marrow. And B12 deficiency can only be found naturally in animal products. So anybody who's having, who's taking a vegetarian or a vegan diet will need to supplement with these foods. The reason I started my site was because I found that so many clinicians weren't taught enough about B12 deficiency. And unfortunately, the narrow learning that some of our clinicians receive leads them to believe that B12 is actually present in leafy greens. And you can see here from this slide that even though haematology found that the B12 level was low, this doctor actually advised green veg instead of B12 injections, which is what the patient who couldn't absorb from food would have needed. So there's many causes of B12 deficiency. And this inability, it's the most complex of all the vitamins, really. This slide will show you that dietary lack is a cause, and also low stomach acid can be a cause of B12 deficiency, and whether that comes from acid suppressants or natural. As we get older, we have less stomach acid, and we need stomach acid to be able to unbind B12 from food. You may have learnt about pernicious anemia, which is the autoimmune B12 deficiency, and that is defined by a lack of intrinsic factor in the stomach, which helps to transport B12 to the small intestine and then to the blood. Anybody who's a midwife will know hopefully about the use of nitrous oxide in labour, and that the fact that that can completely inactivate B12 in the body. So that can then have effects on the mother and then a breastfed child who may not be accessing any B12. Metformin is a drug commonly used for diabetes, and as I've said too, acid suppressants are also key drugs that stop absorption for B12 from food, and there are many genetic reasons. Gastric bypasses also have an impact, and parasites also stop B12 from being absorbed properly. So there are many reasons why a patient may become B12 deficient. So if I may, I'm just going to play a very short clip of a video just to demonstrate how serious B12 deficiency can be.
Pediatrician Dave Carr was told he was suffering from a rare, incurable neurodegenerative disease. He was about to die, demented, blind, deaf, and in a diaper, before he was correctly diagnosed with a vitamin B12 deficiency, a condition that would have been easy to prevent and inexpensive to treat if it had ever even crossed his mind. Dr. Carr did not know that low B12 was shrinking his brain and demyelinating his nerves. He did not know that masked B12 deficiency damage can look just like MS or Parkinson's or Alzheimer's or autism.
There's no way in the world in the year 2005 that a vitamin deficiency can do something like this.
And yet, B12 deficiency causes serious problems ranging from fatigue to depression to memory loss to heart disease. What your doctor doesn't know about vitamin B12 can hurt you.
Low B12 levels are associated with a progressive cerebral atrophy.
It's not a placebo.
The neurological manifestations well precede the hematologic manifestation.
Well, let me simply say you can't live without it. Vitamin B12 deficiency, if left untreated, results in death.
So you can see from that short film how serious B12 deficiency is, and that Dr. Carr, who was a paediatrician, hadn't learnt enough about B12 deficiency to recognise it in his own health. You'll see a lady speaking in that, and some of you may be aware of her, Sally Patullock, who this is a photograph taken in 2015, where I ran a conference on B12 deficiency, and also in 2016. And Sally wrote a book along with her husband, Dr. Jeffrey Stewart, called Could It Be B12? So I use a lot of Sally's research on the website. That poster that Sally and I stood against shows that how wide-ranging B12 deficiency is. It can affect males and females and any age, from a unborn baby right up to the end of life. But unfortunately, again, due to limited learning, many of our doctors understand that B12 deficiency really only affects women over 60. There are so many signs and symptoms of B12 deficiency, and some of them are would be considered non-specific. As I've said, it affects every single body system. So very tricky for a doctor to necessarily pin down. What they do learn is generally focused upon pernicious anemia, which is the autoimmune deficiency. And these are the classic symptoms that a doctor may be looking for in order to diagnose B12 deficiency. There are so many of them, and I thought that rather than me just showing you lists of B12 deficiency, which you can see on the website, is to actually show you what B12 deficiency can be misdiagnosed as. So dementia and Alzheimer's are there, and one of my first presenting symptoms and most worrying was a loss of memory. But it can affect depression, can be a major presenting symptom, and exhaustion, so chronic fatigue, ME, fibromyalgia, you'll see there, Parkinson's disease, the tremor can be very commonly associated with B12 too, congestive heart failure, anemia, vertigo. So the connection with B12 deficiency and poor mental health was discovered over 100 years ago, and you may have heard the term megaloblastic madness, and megaloblastic referring to large red blood cells and megaloblastic anemia. So mental health is key in B12 deficiency. But like Marjorie had said, many mental health patients may not have physical reason explored fully enough when their diagnosis occurs. So unfortunately too, as you'll have seen on the previous slide, anemia is often what doctors are looking for in B12 deficiency, but that is not always present. So how is B12 tested for? The common test is the serum B12 test. However, it has its limitations. Unfortunately, it tests all B12 in the body, and that's active and inactive. And there are many documents which some of our doctors are not aware of that state that the clinical picture is of utmost importance, because if you are within range on these serum B12 tests, then it may be that your diagnosis is missed. So in the UK, the hematinics assays state that in the event of any discordance, then treatment should not be delayed. And this is because, as you've seen, B12 deficiency can lead to permanent damage. And also the British Society for Haematology also warn there is no gold standard test. So treatment for B12 deficiency, if you can't absorb it from food, has to be injections, and generally is injections, because injections are the most efficient and effective way of getting B12 into the system, and it also bypasses the stomach. And these injections, if you can't absorb from food, are needed for life. There are sublingual tablets that some people can use, and particularly useful if you're a vegan or a vegetarian, but you can absorb. They can be a useful form. So in the UK again, and I appreciate that I'm talking to other people from around the country, other countries. In the UK, 3 monthly injections are generally what people are placed onto once their B12 deficiency has been diagnosed. But unfortunately, a series of cost-saving audits meant that we arrived at this frequency of treatment for patients. And so that really, in general terms, is not enough for most patients. B12 is water soluble, so it needs constant replacement. And this frequency is just based on cost saving. And the very last slide I'm going to share with you, just in case you know anybody who may be B12 deficient or somebody has sprung to mind, then really try not to take any B12 supplements before you're testing, because that can really wildly throw you into the within range result on a serum B12 test, which can then hamper diagnosis. And that's it from me. Thank you.
Tracy, thank you so much. You know, another really interesting presentation, and blimey, I think that really brought it home, the B12, you know, life limiting impact that it can have on people with the video and the work that you presented. So thank you so much for that. And people in the box have said thank you for sharing this really valuable information. I mean, I'm learning things all the time, which is brilliant. So I've got some questions that have popped up in the box that I'd just like to ask the panel about. Now I'll start with Jane. Jane, one of the things that we've got a movement around in America, actually, through one of our board members, is this concept of, instead of people saying to their patients and those that look after, what's the matter? It's more about actually what matters to you. And I think this feels very relevant to
Yes.
actually nourishment and food. But with your expertise, what role do you really think that early career nurses and midwives are best placed to, in terms of making sure that they approach the way that they deal with their patients in this way? What kind of top tips would you give them?
I think one of the things that I learned really early on was to ask patients what are their favorite foods. And as soon as you start, because they expect you to say, oh, here's a list of what you're not allowed to have.
Yes.
And that's, you know, so everyone gets defensive and they think, oh, I can't really talk to anyone in a nutrition profession. Whereas if you say, oh, what's your favorite food? And then it means, you're going to allow me to eat. And it's that start of a conversation. It's rather like one of my other defining moments in my life was where I set up AIDS and HIV services in Nottingham. And in those days, people fled from London because they were so worried about confidentiality breaches. So Nottingham, for those of you who aren't in this country, is very north. So people who were HIV positive used to go up to Nottingham. And I had a lovely, lovely patient called Patrick, and he was a choreographer. And he used to love the fact that I would sit on the bottom of his bed. And he used to say, oh, tell me about the meals that you've been eating. And this little tip I'd love to pass on. And I say, isn't that torture? Because he had Kaposi's sarcoma, which for those, it's a tumor in the mouth and it affected his ability to eat. And I said, isn't it torture that I'm eating all these lovely foods? He said, no, because I know that those little moments that I have that I fancy eating something, I'm just going to remember a little story that you told me. And towards the end of his life, I asked him, what would you love me to bring in tomorrow from home for you? Which food would you love? And he said, oh, I'd love a fresh strawberry.
Oh, wow.
And I took in a punnet of fresh strawberries. And I was disciplined for doing that because they said it hadn't gone through the kitchens and it hadn't been blasted. And I just said, this guy is HIV positive. He's got Kaposi's sarcoma. It is not going to be a strawberry that brings about the end of his life.
No.
And it meant so much to him. So as nurses and midwives, start that conversation. What's your favorite food? Because you're 90% of the way there because you've got them.
Yeah.
And then they'll take notice of what you're saying and you get them on side. And that's a huge part of what we need to do.
What a brilliant tip. We must tweet that out, Hannah, because I think it is sometimes difficult to have the conversation about food, especially if the food that's being served up in the environment you work isn't the best. You know, we all know we've lived with hospital foods and them not looking appetizing. And then the next question, Jane, that's come through, and it often comes through from our early career nurses and midwives, is how do you, it links to your response actually, but what do you advise the best way for young nurses and midwives to go about the senior people or people that are more senior to them that push back, just like the pushback you got about strawberries? So how do they manage that? Because that often does frustrate our young nurses and midwives. But at the same time, they've got to get on with the team and they want to progress their careers. So, given your expertise, what would you suggest they do in that instance?
It's a tough one, that one is. Because I did almost dedicate my first book to my first professor. Had she not told me that, I'm not able to do things in the way that I want to, I would never have got off my backside. So I think there's if you can split yourself down the middle and maybe or actually the other way to do it is to think of yourself a bit like a swan. So think of your legs as being the rebellious part. So you're the legs think about, how can I do this differently? Maybe I talk to a patient in a slightly different way. Maybe I serve a cup of tea in a different way or a mug of chai in a different way, that you're finding those little ways that you're doing it differently. But above, just try and I think this is where the creativity comes in. That yes, you are up against a continual battering ram, and I always was and I always will be. But I think so often, if you're sharing results, and it could be a patient's anecdote, and they just say, oh, this new nurse had just taught to me in a different way, and it's really helped. That sort of testimony will actually change the way that people do things. So I think poke the beast a little bit, but just find your own creative ways, and also just keep dreaming about how you can do it differently when you've qualified. I'm a huge dreamer. Set myself 5-year goals and just say, if I can't do it now, I will be able to, and just practice a few of those skills.
Brilliant. Well, as ever, Jane, we'll be back to you shortly to tell us more about the Solution Initiative and the prizes that are going to be on offer. But I'm now going to come to Marjorie. Marjorie, it linked beautifully with Tracy's presentation actually around the mental health and the importance of nourishment and it affecting mental well-being. How do you think we are now generally around understanding mental health and the importance of food? Because I have to say, when I've engaged with people in mental health services, it doesn't feel like a top priority, and yet it clearly, Jane said to me once that what you eat today will affect your performance tomorrow, and that's scientifically true, but it doesn't seem to be a top priority with mental health services. So, what are your thoughts about that, and how are you influencing it, I guess, in your role at the university working with practice?
I think like Jane said, one of the most important things is to demonstrate a compassionate approach, and that is a way of showing that you really do want to get to know the person. And in nursing, we talk about it as a therapeutic relationship. Developing that is really, really important. And this is one way you can do it. In my research with people with mental health problems, asking them how they could get more involved, they came up with talking about their medication, which I didn't think they'd like to talk about, because most of the time it's not very nice medication to take, and most of them don't want it. But they found that as a common goal that we could start with as a way of getting them to take back control. Now, for them to understand how that, and we had a lot of young people who didn't want to take the medication because they knew it was going to make them put on weight, but we didn't give them the education around that, so that's something we could, I think, education, which is part of a nurse's role anyway, is to help people understand what they're eating, why they're eating it, and maybe find alternatives that might be better for their health. So but it's getting to know compassionately what it is that they like to eat. Like Jane said, that's a really important question to ask. If you're working with people who are not able to tell you that, I'm thinking about particularly in dementia care, you can ask carers or parents, what's this person's favourite food, especially if you're trying to coax them into eating after being unwell, particularly people with depression who may not have the motivation to eat and look after themselves. There's also people with eating disorders who might not be eating the right things that they need to be eating, even though they're eating a little. So it's just finding out where exactly is going to coax them into eating again and getting into healthy routines. But also we need to, in this day and age, we also need to take into account of diversity. Just because we are of a particular culture, it doesn't mean that another culture is going to like the same foods as you. And I'm just wondering about hospital food, how they get around that, really, because the culture around food is a huge area that we haven't even thought about, I don't suppose. Yeah.
I agree, and I think part of this solution is how do these early career nurses and midwives put forward different ideas to tackle that? How do you advocate? And one of the strengths within our Nightingale Challenge community is their passion for advocacy. So again, really, I think that's something we put out there for these people to think about how they might do that. So, and the other thing that come through, Marjorie, from what you said was health promotion in its broadest sense and educating people. We know that within nurses' code of conduct and within our undergraduate education, health promotion is there, but it feels like it needs to come more and more to the fore, and certainly your presentation really flagged that, I think, with the obesity agenda, certainly in this country, and the misunderstanding or lack of education between medication and how that can affect you and your well-being. So so I think something else for people to think about is that health promotion agenda, and have we somehow lost sight of that a little bit in our profession over the years, and is it somebody else's job, or it's not been front of centre because we've been busy doing the treatment as opposed to more of perhaps the holistic side of things? So yes, that's great. Thank you, Marjorie. And Tracy, I'll come to you, and then we must tell our audience about the solution, which Hannah and Jane will be sharing. But we've got another question into the box, which is actually, Tracy, it's a spot on one for you. Does it need a vitamin B12? Do they need prenatal nutrition for child and emotional development and prevention of later illness? So I think the question is how important is vitamin B12 for emotional development in children? And if they don't have it, is there any evidence to say it can affect mental health later on in life when people, have developed a bit more?
Well, B12 is key for development in anybody, and in an unborn child, it's critical, obviously. And their access to the B12 is from the parent. So prenatal vitamins are vital if people aren't eating a proper diet or the best diet. But B12, as you see, an unborn child can have neural tube defects, just like the deficiency in folate. So yeah, absolutely key.
So very important. That's great. So now we're going to hand over to Hannah and Jane. Hannah will start talking a little bit about this challenge. And Hannah was the one that designed these challenges, so it's all credit to her that we're here today. And then Jane, it'd be great just a few words about the prize that you will share with us. So over to you, Hannah.
Okay, hi everyone. Thank you to our wonderful presenters. It's fascinating listening to you all, and thank you to everyone for joining us today. I can see we've got some participants from Moldova and Ghana, and it's really great to have you here with us. So as many of you probably already know, we launched the Nightingale Challenge Global Solutions Initiative last summer as a way to bring nurses and midwives around the world together to tackle global health challenges that are facing us all, and to really provide a platform for nurses and midwives to come together and show their entrepreneurialism, their leadership skills, their innovation, and give them the opportunity to lead on creating solutions to overcome these challenges that we face globally. So as we've heard today, our topic this month is all about nutrition and nourishment, and how we can really prioritise that as part of patient care. And so what we would really love for you all to do is, and we understand that, you're all under immense pressure, so, our hats and hearts go out to you. But if you have time and you want to, we would love for you to get involved in this challenge and to come up with an approach to ensure that nutrition and nourishment are prioritised as part of patient care. And as Jane said at the beginning, we want you to be creative. We want you to come up with ideas that maybe we haven't seen before. And the idea is that over the next 8 weeks, we'll be working together. We'll be holding another webinar like this one, where we'll bring you different perspectives, different approaches. If you join our Facebook group, you'll be able to access many resources, publications on this subject to inspire you and give you motivation. And then at the end, there'll be a global panel of health experts who will select our winning solution, and the winners will receive a prize in some shape or form, which Jane, it'd be lovely to hear from you what our winning participants can look forward to.
So what we've come up with so far, but equally I might be a bit creative in the meantime, so I think we might have a little surprise up our sleeve, is with Nourish, we have a lovely studio which is down in the grounds of a beautiful house down in just outside Chippenham. And we renovated an old Nissan building to have a lovely studio. And pre-COVID, that lovely time when we could all meet together, we would have caring relatives, we'd have healthcare professionals coming into the studio. It's a beautiful space that we have a lovely futon sofa that if you're feeling unwell, you can come in and just lay your head down, have a snooze with my little therapy dog, the Kumi. But we would love to invite the winner to join us with an interactive session with Andreas Winjard, who's my lovely Nourish chef. Now, Andreas is he's a Michelin chef, and he works with me at Nourish by Jane Clark, where we're creating all of our recipes. And we're going to hold an interactive session where we'll give you the forum of telling all of our audience, because we've got a lovely large community with Nourish by Jane Clark, and the healthcare professionals, just amazing food producers. So we'll get the word out to all of our community. And we'd also love to interview you for our newsletter that goes out twice a month, just to bring all of this amazing creativity to life, to make it happen.
Brilliant. Well, thank you so much, Jane and Hannah, for that. So, this is a real opportunity, as we always say with this, for you to shine, for you to do something different, to really be able to think outside the box and share with the world, actually, something new and different, about how you can nourish people with your heart and your soul and your mind and your hands, I think, Jane, isn't it?
Yeah,
It's
definitely.
real, and please don't be put off by, obviously, not being in this country, because we're fantastic now with technology and we can zoom you in and zoom you out to all sorts of fascinating things. So that sounds really wonderful. So I think we've now nearly come to the end of our session together. I know people struggle to sometimes attend these in person, but we do pre-record them and lots of people listen after. So we'll be tweeting out this webinar. So do pass on the message, because I know many of you are networked and will share what you have heard with others. So please do share the word. It is open, obviously, to everybody. And our other solutions, we've had Hannah, I'm going to come to you, but we've got a Ghanaian that's won a solution, haven't we? And we've got.
I think Stefan is actually on the call. He was commenting earlier. Yeah,
So,
sorry.
No, you go.
No, I was going to say we had a team of Ghanaian nursing students who won our first Global Solutions Challenge, which was all around brain injury, and a team of nursing students from Indonesia who won our most recent one. Yeah. So it's great to have such global participation.
And we do hope to do more of these throughout the year and bring you all together, because you're going to all be pushing fantastic new and different initiatives from different parts of the world, no doubt, on this agenda. So absolutely wonderful to have had this time with you. Thank you so much to the panel. I've really enjoyed, I've had fun, and I've learned about lots around this agenda. So thank you so much for spending the time, and look forward to seeing what comes forward. Thanks, everybody. Take great care. Bye-bye.
Bye, everyone.
Bye.